Thank you. And all the best for your elections, ma'am. Now we move on to Dr. Rohith, Georgy, Mathew. In this era of refractive surgery, we will face many people who have undergone refractive surgeries, and also now cataract surgery is become a refractive surgery. So the importance of precise biometry cannot be overemphasized. Dr. Rohith is a established phaco-refractive surgeon working at the Lotus Eye Hospital, Cochin. Over to you, Dr. George.
Good morning, all. I would like to thank Dr. Soni for including me in this IC. So in this era of refractive surgery, the number of refractive surgeries performed worldwide is increasing. So as the post-refractive cataract volume also is slightly coming up due to age. So the refractive surprises are well known, and the refractive dissatisfied patients are also increasing. So what is the key? It's the accurate biometry. So it's just a basic. After corneal refractive surgery, the main is the relations between the anterior and posterior corneal curvature. That is the Gulf-Strands ratio. The normal is around 0.9 to 0.93. Whereas in myopes, if you see, the center area is flattened and the periphery is thicker. Whereas in hyperopes, the center is thicker and the periphery is flattened. So this ratio is being altered after the refractive surgery. So what does the conventional catometer do? So the conventional catometer, it measures only the 3 mm zone. So that is fixed, and the anterior and posterior corneal curvature is already fixed in the machine. So and it doesn't calculate the central corneal images also. Whereas when you do a post-refractive surgery IOL power calculation, the prefixed value is being used. So that is the reason why you get surprises after the surgery. So the era of estimation of ELP in the third generation formulas like Hoffer-Q, Holiday 1 and the SRK-T is that it based on the catometer reading as well as the axial length, resulting in an proper AC depth leading to effective lens position. Whereas in post-refractive surgery, the catometer is varied, resulting in an inaccurate AC depth, resulting in an inaccurate effective lens position. So what is the solution? So there are two ways to approach. One is measuring or estimating the true corneal power, that is objectively a total catometer, and applying correction factor for catometer, like the Pentacam EKR values. This total catometry can be done in the newer generation machines like the IOL Master 700. The other method is using the formula not solely relying on catometer and axial length. Or you can add in the corrective factors of accurate estimation of the effective lens position, like the formulas like the Holiday 2 and the Barrett True K, Universal 2. So if you don't have the latest machines, the older way of approaching is look onto the previous refractive data, which is not available throughout, because if the patient is doing in a refractive surgery in a hospital and the cataract surgery in a different hospital, it will be a difficult sign area. The other method is use an online calculator to get the basic K values and compare the various methods, and the history and the no history method in the SHAMAS 2, you can do the online calculation. It gives a almost precise value. Whereas in the modern practice, you can try for the topography as well as the optical biometry. So in topography, there are two ways, like the Placido. It is basically to evaluate the astigmatism level, the ablation pattern, whether it's central or peripheral, and the other one is the Schimflex OCT, to know the equivalent refraction and the true net power. And like optical biometry, the optical OCT based IOL master calculation, both anterior and posterior corneal curvature is done. So this is inbuilt with the formulas like the Barrett True K post refractive surgery and the Barrett TK Universal 2. So this gives a precise value. So another method is total catometry. This is a novel method combining both telecentric catometer and the swept source OCT. The measures the posterior corneal curvature and it's incorporated in the latest machine like the IOL Master 700, and these our newer formulas are also incorporated in this. So what is happening in a total keratometer? You can see the anterior and posterior side effects of the cornea. The anterior is calculated with 3-point telecentric keratometer, and the posterior one is calculated with the Swepso's OCT. It forms a 3D image behind the cornea, and the formulas can be incorporated into the machine to get the proper value. So same as the IOL means the power calculation, IOL selection is also an important one. So post myopic LASIK correction, always choose for a spherical IOLs where the positive spherical aberrations are always there. And for hyperopic LASIKs, go for a neutral aberrations or a spherical IOL. So these are commonly available IOL calculating sites. ACRS does a good job. And in conclusion, understanding the need of patients and counseling is critical in avoiding dissatisfaction in patients with prior refractive surgery. And IOL selection is an important criteria in that calculation. And the aspherical IOL for myopes and aberration neutral for hyperopes. And Placido Topo for checking the ablation and for planning a toric IOL. And never give over expectation to the patient of getting a glass-free life after refractive surgery, because minor changes can happen, and preferably better not to go for a diffractive lenses. The newer generation EDOF lenses are far better, and the monofocal lenses are extended monofocal lenses also do a better job. Thank you.
Thank you, Dr. Rohith, for that wonderful overview. It's nothing like having a person who does phaco and refractive to outline how to go about